For the next lecture, may I invite on stage Dr. Fahisham Taib, the Pediatric Palliative Care Specialist at Hospital USM. He previously graduated from University College Dublin in Ireland, and throughout his career as a pediatrician, he has obtained further training and subspecialization in pediatric palliative care through Specialist Certificate Palliative Care from University of Melbourne, Australia, as well as Fellowship in Pediatric Palliative Care under the Medical Training Initiative by the Royal College of Paediatrics and Child Health, United Kingdom. Dr. Fahisham will be presenting about community pediatric palliative care pearls. Let's hear from Dr. Fahisham.
Assalamualaikum and a very good morning. My name is Dr. Fahisham Taib. I'm one of the general pediatrician at Hospital University Science Malaysia. I'd like to take the opportunity to thank the Malaysian Hospice Council for inviting me to give a talk on community pediatric palliative pearls. This is outline of my talk. I will be trying to highlight the differences between adult and pediatric palliative care and its definition, and also try to look into the challenges in pediatric palliative care and also the challenges, especially in the community when dealing with patients with pediatric palliative care. I'll also, following that, I probably would try to illustrate a few cases and end up with the conclusion of the talk. Pediatric palliative care has garnered a lot of interest since 2012. There are many changes has been imposed and proposed in order to expand the specialty, especially here in Malaysia. We also know that children, in terms of managing their medical condition and also in terms of palliative care, are quite different. So we cannot assume that children are similar to adults, as stated by Vic Larcher in 2015. Children are not small adults. They have a unique way of dealing approach because of the development, physiology, and also utilization of certain drugs, which can be different from an adult. What is pediatric palliative care? Essentially, pediatric palliative care is an interdisciplinary service that focus on children. Who are they? These are infants, children, either preschool or school age going, adolescent, and sometimes can be up to young adults. And this group of population have a life-limiting condition or life-threatening condition. And the focus should not only covering the children themselves, but also looking after the family members. How do you going to do it? We are aiming or trying to relieve the symptoms, which include physical, psychosocial, spiritual, and also sometimes in practical basis, using a multidisciplinary or interdisciplinary team approach. And this should be from the diagnosis and throughout the illness until the bereavement phase. The second definition is about community-based PPC, and this is a service which is provided outside the hospital setting and utilizing the resources outside in order to support the children by different approach, maybe by phone, by electronic, by going to the house, and the purpose of this is to ensure there's a seamless care from the hospital to the community. Currently, we consider hospital-based support is an essential part of our healthcare systems in order to care and also support for those who have life-limiting illness. But 100 years ago, the care has been basically run in the community, and hence it is important when a person who live with life-limiting condition have a transition, smooth transition from the hospital to community-based. This is to ensure a couple of things. One is regarding the communication and practical issues, because when the patient is in the hospital, um, the communication may not be an issue because the doctor is available and explain to the parents and also perhaps to the older child. But this will be a problems when the patient is going to be sent home. This is primarily because of there's a issue related to lack of information and also issue related to the planning of care itself. Secondly, is about the problem related to psychospiritual, because this is not really explored even among the children with life-limiting condition. We often focus more on the physical aspect and maybe psychological aspect, but not really psychospiritual distress, which may manifest later. And the third one is about the inequitable access, especially for those with non-cancer. I think a lot of the service often focus for cancer, and because of the available financial mean or muscles in order to support these children. But those with chronic, debilitating, life-limiting illness, for example, rare disease like mucopolysaccharidosis, often has been left behind and without any resources, especially in the community. Hence, we know the importance of community palliative care service, because there are many benefits of this service. Um, some of this service may support the patient and also the family, especially at home. This is dependent on the planning and also requests and wishes of the family members and the patients. Some of the benefits that I want to highlight here is to improve the symptom management, because although symptom management can be optimized in the hospital, however, this also should be monitored and also optimized when the patient at home or in the community. Number two is to improve the end of life experience. Often, the discussion in Malaysian context regarding end of life can be a little bit difficult. This is because of the taboo and also the sensitive issue when discussing about life and death of the patients, especially in children. Therefore, it is essential to look at what are the wishes of the family, and also if the children or the child can verbalize and tell you the wishes. Therefore, it is essential to fulfill it. The second part of it is the preferred location of death. Although uh, commonly it is very difficult. It depends on the family preference and also the availability of the support, especially in the community. The third one is to improve the communication, because we probably will need somebody who can navigate the family throughout the journey, and also looking at the potential resources available in the community. And also the last one is to decrease hospital stay and visit. As I reiterate just now, there are many differences between pediatric palliative care and also adult palliative care. For example, in pediatric palliative care, there's a lot of rare diseases. For example, in metabolic diseases, um, bone diseases, and also it has a wide spectrum from premature uh, infant, preschool, and also it can go up to adolescent as well. And we know as well we have to deal with the parents as a caregiver. The drug of choice can be a little bit different because there's a limited use of, for example, like opiates in children. The decision making is made by the parents, and also there sometimes can be ethically challenging and morally also can affect the doctors who are caring for these children. There are many challenges in pediatric palliative care, especially in the community setup. For example, like I've listed there, in terms of home versus hospital care, because I mean that depends on the family preference. In terms of availability of the supportive care in the community, in terms of communication, because you have to communicate sometimes with the child with the children themselves, and sometimes most of the time with the parents in terms of projecting what the prognostication for certain rare diseases in terms of age spectrum because their understanding mature perhaps depending on the developmental understanding in terms of end of life because the option can be limited as well, and then you don't want to be seen as abandoning the child. Similar to the community palliative care. So, I mean, like you are attending a patient in the community, and sometimes the ethics of being at home would be slightly different, and they might not want to come home, and that also pose a challenge in terms of ethical consideration. I mean, there are other things, maybe in terms of caring of children. I mean, a lot of the healthcare workers are not happy and not comfortable doing that. Sometimes, because of the family members around them, they've got unrealistic hope. There's also issue related to how adequate and optimized in terms of reducing the suffering and also deviation of care as well. So I like to highlight a couple of cases because I mean like the essential talk here is to pick up a couple of pearls from community palliative care. And the first case is about a toddler. Let me name her as A. She has recurrent ovarian germ cell tumor, and this ovarian tumor is extending or growing intra-abdominally. We have to use a lot of morphine in term to control the symptoms. But at the end, during her end of life, unfortunately, the parents use kratom or ketum to replace the use of morphine. Although at that time as well, he was still on the fentanyl patch. Despite of those things, I mean, like despite we do not have any evidence to suggest that kratom is effective for cancer pain, we learn a couple of things here. Okay, number one, perhaps at the end of life, sometimes it is good to allow because I mean, like although ethically challenging in managing toddler because they were not able to verbalize, they were not able to tell you, but in order to achieve appropriate, adequate quality of life subjectively, sometimes you also look at if this is not harming the child and if this is causing comfort rather than discomfort, sometimes this can be allowed. And you have to monitor this dynamic of the family and also unwanted side effect if it is available. So what I want to highlight there is that sometimes the best interest of a child can be challenging because you are trying to look at what are the expected benefits, what are their wishes, and the child herself would not be able to make an autonomous decision. So you have to balance between anticipated risk or burden. Okay, so at this point, sometimes if the parents do not, you know, perform or do any harm to the child. Sometimes you can ascribe to the principle of just good enough, least harmful, suboptimal care, but following their wishes, respecting their wishes, not causing harm or suffering to the child. So sometimes this can also be discussed and be taken adequate decision by negotiating the goals of care. The second case that I would like to highlight is that I remember this case vividly, where B is a girl who's got diagnosis with acute lymphoblastic leukemia. We know that acute lymphoblastic leukemia is a good prognostic if it's treated and undergo chemotherapy for children. It does not possess any poor prognostic unless it becomes hyperleukocytosis or with any other sequelae like neurological um, problems. But the parents keep on refusing to take this treatment. Do we consider this as a neglect of care? We often encounter, I mean, like the family who have a low socioeconomic background, and because of that, they kind of like default treatment, unable to attend, and also refusing the treatment. I mean, in pediatric, refusing of treatment, refusing the rights of a child to get a better healthcare can be considered as neglect. And often, in this case as well, you have to negotiate to find what's the best way in order to care for the child. Is it, involving the child protector to bring the child to the hospital, or do we suffice to give pain relief and ensuring that the patient is comfortable and not suffering. So sometimes you look at the potential issue related to destitution, inability to come to the hospital because of transport or financial issue. This has to be looked into holistic way in terms of resolving the issue. Sometimes the context of which we are dealing with can be challenging because, I mean, can we consider this as a neglect of care? If not, then if this is a neglect of care, then we should be involving, um, you know, uh, the child protector in order to bring the child to the hospital. Can we also promise curative? This is also challenging as well, because although the prognosis is good. However, I mean, like there are also hard and difficult journey ahead in terms of overcoming infection and also disease itself. And then we need to understand as well why the parent refused. Is it related to the financial context, or is it because of certain issues that might cause harm to the child? So we need to look into the contextual factors and long-term challenges. And the best thing is to look into four different domains. What are the medical indication? What are the patient preference or the family preference? What are the contextual issue, and also the quality of life based on what we are going to intervene. Case number three is an 8-month-old with AML, and she had hyperleukocytosis. She was living perhaps 3 hours from the hospital that we are in right now. The problem is that when the patient has got issue, I mean, if you can see that the face is there's a facial nerve palsy on the right hand side there, and he was diagnosed with refractory AML, and they want to go home, but their home where they are going to go is very far away, perhaps about half an hour from the nearest small town that they're living in. So there was no real support. So how can we collaborate with the team in the community, especially in the domiciliary setting, to ensure the end of life is better being uh, done appropriately at home? Another case is a 17-year-old adolescent who has left sclerosing rhabdomyosarcoma. Because of the overgrowth of the face, he became introvert and not wanting to go out. This occurred during the MCO of our COVID-19 pandemic. And in order to do so, the community team has to build trust and discuss many things related to adolescent issue, because he's got many fears, many hopes, many preferences, and good memory. And unfortunately, when he was with us, he was basically, because of the age of 17-year-old, he was an adult, and this was unfortunately not plan properly in terms of symptom control. And he needs a lot of psychosocial support as well, because of the problem related to the body image, and he feel that he has some issue related to appearance and uh, mingling with other family members. So in essence, home care is where we have to break the bad news, where we have to plan and make a appropriate planning in terms of end of life, in terms of medication, in terms of um, supporting and also educating the family members. And this would include many things such as nursing care, emotional support, and also try to listen to their concern. So, what is the take home message? So, we know that in community palliative care, the approach must be individualized. However, in order to reach the goals of care, it has to be related to ethical issue, and sometimes we have to allow the wishes to be intended. We have to also communicate appropriately so that shared decision making can be achieved. And lastly, is that support is essential in order to make sure that pediatric palliative care, especially in the community, can be achieved through a seamless care from the hospital setup. With that, thank you very much.
Thank you very much, Dr. Fahisham, for that very enlightening talk that also touched a bit on ethics side. I think there are some questions, but we will try to address the questions during the Q&A session. So I'll go backstage for a while and I'll bring up the three speakers, if I can, to try and address some of the questions or some of the topics that were only briefly touched during the talk. See you all soon.